Thanks, everyone, for sticking around. We're certainly so glad to have all of you with us. This is a tremendous time to be hosting this conference as we look at all the different various facets of healthcare. And for this panel, I think we've got a really exciting conversation that we're going to get into in terms of choosing top healthcare. And how I want to focus our conversation today, we are going to look at this from a pre-pandemic world to a current and post-pandemic world. And so we've got with us a great group of speakers who will walk us through all of this. There is one speaker that we're expected to join us shortly, Dr. Paul Keckley with the Keckley Report. But before we get to our speakers and hear what they have to say, I want to first thank our sponsors for all of their support for this conference: Cigna, Children's National Hospital, the George Washington University, Kaiser Permanente, Home Care Connections, and Duplain Global Enterprises. Thank all of you for your support and for all of your efforts. And now what I want to do is hear directly from our panelists, and we're going to start with Ben Harder. He is with the U.S. News and World Report. And for anyone who has applied to college or even looked for a hospital, you know they are the gold standard in terms of rankings of everything. And so, Ben, we are so happy to have you with us today. Talk to us a little bit about the rankings and how this process plays out, but also talk about it in terms of where we were pre-pandemic, and also if perhaps we may see something vastly different coming out of the pandemic.
Sure. Thank you, Eric, and thanks for that kind introduction. So just a word of orientation around U.S. News and World Report. We've been a consumer-facing publication for about 90 years now, originally as a magazine. About 10 years ago, we went primarily online, and all of our content is free to the public. So we have actually been able to greatly expand our audience. We get over 100,000 people a day looking at our healthcare data alone. And that doesn't even include our political coverage, the college rankings you mentioned, Eric, and all the various other rankings and content that we publish. So we're very much about providing informational service to the public and helping them make better life decisions. So my area of focus is healthcare. That's all I do all day. And I have a team of statisticians, data scientists, analysts who work with me on that. We maintain the website component, the component of the U.S. News website focused on healthcare information, particularly the hospital rankings. We also evaluate rehab facilities and nursing homes. We have a profile of essentially every doctor who practices in the United States, almost 100,000. There are almost 1 million physicians. We have profiles of each of them, so you can understand what their specialty area is, where they practice, which hospitals they're affiliated with. So all of this information is available at usnews.com. With respect to the hospital rankings, which is most of what I have my team doing from day to day, we've been publishing those rankings now since 1990, so a little more than 30 years, and they've evolved as the American healthcare system a great deal in those 3 decades. And I think what you commented on, Eric, is that there will be further evolution. In some cases, trends that already existed were really accelerated by COVID. And so those will factor into to rankings in various ways in the future as we continue to evolve the approach that we use to evaluating hospitals. So just a word or two of orientation to those rankings. We evaluate every hospital in the United States that takes Medicare, the largest insurance company, largest insurance payer in the United States. So there are over 4,000 hospitals that we evaluate each year. And we don't set foot in those hospitals to evaluate them. We use rich data that we're able to obtain from the US government that provide us with a patient level record of every encounter that a patient had in that hospital that was paid for by Medicare, the Medicare plan. So as you can imagine, the reason that our rankings are focused exclusively on US hospitals at this time is that that's where we have this rich data set. It would be somewhat akin to having the receipt for every person who ordered a meal at every restaurant in your country. And you would be able to tell from that information which restaurants were popular with couples who were out on a date night on a Friday night or a Saturday night, and which restaurants were popular with families who come, for certain dates every year, year after year, as their kids celebrate birthdays and so on. And so there's a great deal that you can infer from this rich data set that we're able to obtain from the US government, not only about what services different hospitals provide, what type of patients they serve, but also what their propensities are to apply different treatments, what sort of outcomes they achieve, how well those patients fare over time, and so on. And so part of what we do is profiling the hospitals in terms of the services they offer, and which types of patients make sense to seek care there. And then we also compare them on their performance in similar groups of patients. And so that's what you see as our ranking. So there's a great deal more than just taking a bunch of hospital names and putting them in a list. It's really a very multifaceted look at the services that hospitals provide and how well they provide them. So at this point, we now evaluate hospitals in dozens of different services, and those range from coronary artery bypass surgery, the classic heart surgery, to hip replacement surgery. We look at, we evaluate transplant surgeries. We evaluate various types of medical care, including care of diabetes and endocrine disorders, and so on and so forth. So depending on the needs of a patient, that patient or her family or her friends or her embassy staff or whoever is supporting the decision there can get a great deal of granular information on the hospitals available to them. And then we also evaluate hospitals by region. So we have a ranking of hospitals in the Washington, D.C. metro area, for example, separate ranking for hospitals in the Baltimore, Maryland region. And then we evaluate hospitals across all of the services they provide, and we publish what we call the honor roll, which is the top 20 hospitals across all of the services that US News evaluates. So I'll stop there. Eric, you may have some follow-up questions, but happy to come back to any of that.
Yeah, and we're going to get into all of this because I know I would imagine not only are you guys the gold standard, but you are also basically the compass that so many of us, both inside the United States as well as around the world, are looking to in terms of where can people go and find the best services for patients. And so we definitely want to be able to delve more deeply into a conversation about this, particularly what this will look like and also in how these rankings might be impacted given the global pandemic that we're seeing. Because while the pandemic has certainly had an impact, particularly around issues of respiratory care and things like that, we do know that this virus has also led to other health issues, also including mental health care. We had a panel discussion about that yesterday. And so I would imagine that is something that's going to be front and center in terms of the rankings that you all are doing. And so we certainly want to have a conversation about that. But I also want to bring Dr. David Vequist into this conversation as well. And he is with the Center for Medical Tourism Research. And that brings a whole nother component to this, because while the U.S. News and World Reports and the rankings that you guys are doing focuses on what's happening nationally, Dr. Vequist, the work that you have done focuses on what's happening globally and where people are moving around the world for different types of treatments. And so if you could just talk a little bit about your background and what you're seeing right now in the trends in the field of medical care. I think that's something our viewers certainly would welcome at this time.
Excellent. Well, thank you very much. Yes, as you mentioned, my study is looking at, if you will, patient consumerism, which is the health-seeking behaviors among consumers. And particularly post-pandemic, you're going to see that cross-border care is the next diplomatic issue of the day. I recently had an article that came out in La Forma, which is a major publication in Mexico, talking about vaccine tourism into the United States. And we've uncovered evidence that there is hundreds of thousands of people from Mexico coming in for
so that's going to continue to be an issue
and a opportunity that we should be looking at. Again, as part of my studies, I've been looking at things like the amount of people that are coming into the United States to hospitals and the people in the U.S. going out. And there's some breaking news, Erica, that we have to report at this session. It's pretty fascinating. This is all pre-COVID numbers, but they're very good numbers from the Bureau of Economic Analysis under the Department of Commerce, looking at balance of payments or balance of trade numbers. And as most people know, after 9/11, we saw a very severe decline in the number of foreign nationals coming States to receive, for example, health care in the United States. Altogether, we lost between 1999 approximately to 2012, lost about 27% of the total market share that we had in the United States. Went down from $1 billion to hundreds of millions. And then we've seen a steady increase since then up until 2019, and it was an increase of about 50% overall. The largest, if you will, trading partner of people that are coming in for procedures into the United States. And this is going to be fascinating because this is going to bring up all sorts of issues, diplomatic and otherwise, was China. China trade in the United States of healthcare services of around 192 million in 2019. That was tops among trade that comes into the United States. In fact, it was actually more than all of the EU residents would spend in the U.S. for healthcare, which was about 162 million. Other large countries that were bringing residents to the United States were countries like Canada, 81 million, Mexico, 69, UK, and Saudi Arabia, both about 60 million. The one last point, the number of Americans going abroad. So this is a fascinating issue of tourism, is Americans seeking care elsewhere. So these numbers are, again, hot off the presses and fascinating because they're pre-COVID. It'll be interesting to see how trade and business respond to the pandemic and how those numbers are effective, particularly, for example, as we saw earlier, the Chinese numbers, with the new if you will, Cold War or whatever is going on with China. It's those number of Chinese coming to the United States in terms of medical tourism. People going outbound from the United States, we saw, again, a fairly steady increase from 1999. It was never impacted by 9/11. And this is, again, just off the presses for you and the participants. In 2019, compared to 1999, the total increase in the number dollars flowing outside the United States to foreign nations went up 290%. So it's in the $600 million range now, according to surveys from BEA. And the largest amount of that, most people here in the Southwest, I'm reporting from Houston today, can tell you that Mexico is one of our largest trading partners. And if you ever see the number of dental clinics and other types of health business across the border in Mexico, you know that there's a great deal going there. According to BEA, it's about $230 million of American dollars going into Mexico for health services, which is the same amount as the Americans going to EU and Canada, which is about 105 million, 22 million combined, much more, sorry, about double that. Other major partners that we're seeing American to is Colombia, had 48, Costa Rica at 35 million, Germany at 26, India at 23, and South Korea at 17 million. So it's really fascinating to see these inflows and outflows. The pre-pandemic, the big winners were the United States, obviously, which was getting 600 and total economic impact. Mexico, which was getting probably $160 million total impact. The big losers were China, losing hundreds of millions of dollars for their people going abroad to the United States just alone, not include Chinese going to Thailand, and then also Canada, which was losing potentially a little less than 100 million in terms of people leaving Canada and going to the United States. But I guess the last point in healthcare, economic trade isn't, because when you have these inflows and outflows, for example, vaccines for residents of Mexico, is there really a loser, or is this just business and everybody trying to take care of each other? And does China really lose having people come to the United States and receive care here and be better?
And I think that gets us to the central theme of our conversation today, choosing top healthcare. And Ben, I certainly want to bring you in, given the numbers that Dr. Vequist has laid out for us, because this is pretty fascinating when you hear about that number in terms of the rise in people from the United States leaving the country for healthcare, but then the rise in people, particularly from China, to the United States seeking healthcare. When you all are compiling your rankings in terms of healthcare across the board, are you seeing these types of numbers, or are you just simply focused on just the care that is provided? And so if you could just talk a little bit about the methodology and the data that behind those numbers, because I think it's fascinating when we typically think of the United States almost as a monolith, if you will, on healthcare, given the innovations that we're seeing across the entire nation. And so talk a little bit about that, and that could probably, I think, help give us some context as to why we're seeing so much of this outflow and inflow regarding medical tourism.
Yeah, it's a great question, and I think there is a lot of matching activity going on, and that's what we're seeing both with the outflow and the inflow. I think there are a couple of trends at play there. One is that there are enormous disparities within American society, not only around wealth and race, but access to healthcare. And so there are many people who, for one reason or another, cannot afford or cannot access healthcare in the United States, even though they live in the United States, and that's driving a lot of that outflow, where they may find cheaper or better quality care than they would otherwise be able to obtain. At the same time, the leading institutions of American healthcare are tremendously good at what they do. And when it comes to treatment for advanced diseases, rare diseases, cutting edge clinical research, and so on, there is a smorgasbord of choices within the United States. Really, any of the hospitals on our honor roll, and probably some that are not, but are close, are exceptionally good at pretty much everything they do. And so if someone is sick and they have access to one of those institutions, it makes a whole lot of sense for many of them to come to those institutions, whether they live in the United States or not. And so that, I think, accounts for the inflow. And so we see these seemingly contradictory movements, but it actually makes sense from an individual perspective. And that is what our methodology is also designed to do, which is to help individuals or individual families make the most rational, relevant decision for their particular circumstances, including their clinical needs, where they live, and which health systems or hospitals are in their insurance network, for example, if they're U.S. residents. So you asked about the methodology, and I would say there are three broad components that we use in the methodology. The first and most important is outcomes. In other words, what happens to patients? Do they get better? Do they get worse? Does the hospital not help them achieve the outcome that they want, whether that's surviving a rare disease or recovering the function that they may have lost due to a stroke or an injury or osteoarthritis or so on. And so for that, for the calculation of outcomes, we use this incredibly detailed data set that I mentioned earlier, where we have information about individual patients, what conditions were afflicting them before they came to the hospital, what care they received in the hospital, what happened to them after they were discharged from the hospital, and so on. And so we can track individual patients anonymized, so we don't have their name or their phone number or their address, but we know a great deal about them, including their sex, age, their where they live, and so on. We can track that person through their healthcare journeys and understand when a hospital touches them or people like them, does it help them or does it not help them as much as other hospitals? And so that's the largest and most important component of our methodology. We also survey tens of thousands of physicians every year and ask them a simple question, which is, where would you send your most challenging patients? In other words, a referral question. And, for example, if you ask oncologists or other specialists who treat cancer, where would you send your most challenging patients? There's a small number of hospitals that they name again and again and again. And so that expert opinion is important for us in understanding aspects of quality that may be difficult to capture, even in the rich claims data set, rich data set that we have, but that really do differentiate hospitals, particularly those that are at the bleeding edge of advanced research. And so one of the things that we and others who've independently looked at this have found is that our expert opinion scores, that component of our ranking, matches up very well with which hospitals are doing advanced research, in particular clinical research, with new therapies for specific diseases. And so the hospitals that oncologists name are the ones out front in innovative cancer care. The ones that cardiologists and heart surgeons name are the ones that are have invented new therapies for heart disease, and so on and so forth down the line and through the specialties. So that expert opinion component would be the second piece that we look at. And then we also look at certain structural characteristics of the hospital, including things like advanced technology. Is the nurse staffing adequate to the level of needs of the patients, and so on? And so those characteristics of the hospital, there's a great deal of data that those are important for helping patients achieve the best possible outcome in their circumstance. And so that's also an important component of what we do.
And so, Dr. Vequist, when we are looking at these outflows and we're looking at all of this movement in terms of what's taking place, what are you seeing in terms of the flow of people and the demands and some of the trends that you're seeing, particularly as we look at where people are going for different types of care?
So it's a great question, Eric. What we've known for a few years now is that more intensive care tends to travel via air and tends to go farther. In other words, travelers that tend to fly hundreds, if not thousands of miles for care are typically getting more invasive care. People that tend across borders, for example, in the EU or in the United States going into Mexico, are typically seeking less invasive care, for example, dental and things of that. And the other thing is, you and I conversation earlier, it's a really interesting field because there are so many different specialties and areas in which people travel for healthcare, health-seeking behaviors, traveling across borders, which includes things traveling for surrogacy tourism, traveling for doctor-assisted suicide tourism, traveling for psychedelics, for mental health tourism and things of that nature. Well, there's a very interesting story that we can get into another time about, for example, people traveling for gender reassignment surgery. And all these different niche areas are very fascinating. And so what we find is that different populations have different aspects but access to be one of the big ones. What my colleague over at Harvard Law School, Glenn Cohen, calls legal arbitrage, or traveling things that are not accessible in your area because of regulations, because of laws, and going somewhere else.
Thanks for that. And we just have Dr. Paul Keckley of the Keckley Report has just joined us. So thank you, Dr. Keckley, for being with us. And if you can just share a little bit about the work that you're doing. I'm sorry, I just got something popped up on the screen. If you could just share a little bit about the work that you're doing, Dr. Keckley, for our audience. And thank you once again for joining us.
My true north is connecting policy and industry in healthcare, because the two operate in divergent swim lanes. Policy lags industry changes and innovation. So I was interested in listening to David and Ben describe data-driven insights that consumers use to make decisions. So industry's way ahead of policymakers with respect to consumer decision-making.
Nothing new there.
Huh?
I said nothing new there.
No, but what happens, and there is a bit of a disconnect in this discussion and some of the policies that have to be reconnected. One is if the front door to the system and the true north is a transition from facility-based services in many cases to home-based services, and that primary care becomes more holistic with dentistry, mental health, ophthalmic care, nutrition, and so on. Ben, I don't know of any of your reports that have really zeroed in on that. I think that's a huge opportunity. And David, I've looked at tourism from the vantage point of employers and how they're thinking through that back to the days that Hannaford Brothers was advertising doing spine work in Thailand. But short answer is I try to understand where healthcare is through the lens of changes in the clinical, technological, capital, and consumer environments, and then contrast or align those with policies that either are barriers to introduction of better ways of delivering care that's valued, or to sources of capital that groups can use to advance those innovations. And the last thing I'll just say is one of my interesting areas is just looking at how certain organizations find it a lot easier to be forgiven than ask permission. They're not paralyzed by the way our system operates. I remember in the White House, somebody observed that we are addicted to radical incrementalism in healthcare, and that stuck with me. That just kind of hit me. That is true. We're not thinking about the future of healthcare. We're thinking system, and I think we ought to have that discussion about the future of the system. Got some good minds on this call, so we could start it there.
Thanks for bringing that out. And I want to go to some comments that you just made, Dr. Keckley, but also some things that Dr. Vequist just mentioned. And I want to get a response from all of you on this, because Dr. Vequist, you mentioned gender transformation, assisted suicide, psychedelic drugs. I mean, it seems to me that sometimes medicine can get so far ahead of where we are, as Dr. Keckley just mentioned, particularly in terms of the policy. But also, I wonder, what does that mean also for you, Ben, in the rankings? Like, is medicine reaching or sometimes getting to a place where you may not even have the methodology at this time to be actually determining where those rankings should be, or if in fact, should we be doing a ranking on this? So for example, the issue of assisted suicide, is that something that, you would really want to rank? But we certainly know that there are people who are looking for that type of service. In addition to that, gender transformation, that's something that is becoming increasingly more normalized in the United States, but how is that being taken around the world? And so all of this is requiring, technology and innovation. And sometimes that's moving even ahead of where we are in terms of what's happening in Washington, but also maybe with some of the work that you're doing also, Ben. So Ben, let's start with you on that. Dr. Keckley, I want to follow up with you, and then Dr. Vequist, you'll bring up the rear.
Sure. Yeah. Thank you, Eric. That's a great point. And I think you also had mentioned earlier that you wanted to touch on the impact that COVID and other trends in healthcare will have. And I think Paul brought up a really important one around this concept of integrated delivery. The health systems are increasingly, it is a health system that is making decisions about what to provide, what services to provide, and where to provide those, rather than individual hospitals. And those health systems are doing more and more to deliver care to people who may not need to be admitted to the hospital. So they may get care at home, they may need outpatient care, they may want telehealth, and they may need behavioral health, which historically was not provided in the hospital setting except for inpatient psychiatry, very specific population, but now health systems are increasingly devoting resources to how do they address the mental health needs of their patient population that lives in their community, because they know that if they don't do that, that those patients will end up eating up a tremendous amount of resources of clinical care that they don't need to eat up. And of course, insurers are very interested, people paying for healthcare are very interested in that as well, because there's an enormous cost savings opportunity if you can prevent unnecessary healthcare. And so our methods are evolving to look at those things as well. We're looking increasingly at what's happening outside of the hospital and around preventive care. Are there conditions? There are conditions, we know this, but is there variation from hospital to hospital, and how effectively hospitals manage their population to prevent ambulatory sensitive admissions, for example. Similarly, we see a lot of consolidation, as I alluded to, in healthcare. So these health systems are consuming individual hospitals, independent hospitals, and then trying to integrate them in efficient ways so that they can clinically collaborate on services that are better provided at one site than another. And those sorts of changes, I think, are being accelerated in many cases by COVID, because some of the more marginal hospitals are under tremendous financial strain right now, where some of the stronger systems have actually been strengthened by the pandemic financially. And that was a pre-existing trend, but it is now accelerating. Telehealth has also accelerated that. There's more opportunity for expertise to be projected through time and space to sites where the specialist might not be available. And then there's also more and more activity around collaborations. Leading institutions, US-based and elsewhere, are collaborating with other hospitals, both in the US and abroad, to, often it involves a branding relationship. So there is the campus of whatever clinic in another city or another country, but there's also a clinical collaboration component of that. And so we're interested in understanding how effective are those collaborations? Does this brand mean the same thing in its home base as it does when it's delivered at 10 other campuses that have a collaborative affiliation with it?
Keckley, your thoughts?
Well, there's a lot to digest. I guess the two things, I think systems of the future, systemness, is an aspiration and a destination for anybody that's going to be around 10 and 15 years from now. Some of those will have their roots in the acute sector and others won't. And I think to the extent that data sharing with individuals through technologies that enable synchronous self-care, we make decisions in the teachable moment, know what the treatment options are, know what the costs associated with that are. That's true north. And when Ben gets around to rating all those that have those capabilities, then we'll be there, I guess. But second, the population of transgender or whatever population we define, that's a matter of data. I'm reminded that the more we know about this industry, the more we realize we don't know. So there will be, I think, a national discussion fairly soon about how data sharing around science can be expedited. And this bench to bedside delay, which David, when I was at Vanderbilt, all of our folks used to say 17 years. I don't know if it's still the case, but I think that's just simply not in sync with the reality of how data is created and made available. If we can create a vaccine from mRNA methods in 12 months, we should be able to make science more accessible and quicker, but we're not even close. So that's it. I will tell you, when I was running the evidence-based medicine programs at Vanderbilt, it was fascinating. You digest 80 clinical trials a day that are published in 20,000 scientific go through and parse in certain ways. There are other systems of the world that do a better job of making the science part of their regimen for coverage and payment than the US system. We can't put our chest out and say we're doing that well.
Follow up with you, because yesterday we had a panel on innovations in health, and each one of the doctors on that panel spoke about some of the work that they were doing, and it was truly fascinating. And the one that stood out was the doctor from Kaiser, who talked about the sleepless nights and how they had reduced this breast cancer screening from 30 days to now 30 to 60 minutes. And that basically you could go from a screening to, if in fact there was a problem, to treatment in a matter of days, if not a day. And so we are seeing, I think, this move, and like we're seeing not only innovations, but we're seeing, I think, all of this move at warp speed. Does that not give you? Eric, does that not give you any kind of confidence in terms of where we are, or at least where we're headed?
Well, I didn't hear you talk about the approvals that had to happen between the time they demonstrated a 60 to 30-minute reduction.
Well, yeah, that's true.
What ties up the policy world and the reason the gap between science and policy is widening is we don't have the apparatus in place to mass and do the meta-analyses and develop knowledge from the data to the rate it's being created. So I know that scientists can create these kinds of exciting breakthroughs, but how it iterates down to a policy change. Just this week, we saw a formal announcement that we probably ought to be doing colonoscopies for people at 45 instead of 50. Did you see that? Well, guess what? We knew that, right? That's not news, but now we're formalizing that process. So a great discussion for this conference will be how we narrow the gap from data to information and then direction. And it's in that bridge from data to information where regulation and policy slows things down.
Well, I think every conference that will have a policy component, especially we're talking about the United States, I think there's always going to be that concern. I mean, right now, we're looking at a policy making apparatus that is more akin to a circus than it is actual legislative and policy making. So that's a conversation that I thought was already baked into this entire conference that we were having. But Dr. Vequist, I want to come back to you since we're running out of time here. Given where Dr. Keckley is and just given where we are right now, give us your thoughts in terms of where do you see, particularly with medical tourism, and where it may be headed, and also, and what's the driver? Are people driving this, or is the science actually driving this? And give us your thoughts on where you see this going.
But I'd tie it into your very insightful question from earlier. It comes down to two large groups of stakeholders that are having an oversized impact on healthcare. And we've been seeing that growing throughout the years. And one is your colleagues in the media. If you look at since the pandemic and the oversized role the media had to play in terms of dissemination of information about the virus itself, the origin of the virus, the treatment of the virus, the vaccines, that has come through primarily the media. And then the second large stakeholder that's increasing in importance has been crowdsourcing of information, particularly through the internet, which is good and bad. Can we be honest here in terms of healthcare? So some ground work that was done by the Pew organization a few years back showed that in the United States, the most common uses of the internet, and everybody try to keep your minds out of the gutter, is number one is email. Email's the killer app of the internet. Number two is social media. And number three is healthcare. And so searching for healthcare and looking for healthcare information on the internet is the third most common thing that people use the for in the United States. And there's several clinical studies looking at a variety of different areas that have shown consistently that about 66% of all the information on the internet is either out of date or incorrect. And so this crowding of information, although it's increasing in importance, and it's becoming much more difficult to trust, if you will, because there's so much of it. But the internet and medical travel, medical choice, the patient consumerism is increasing because there's more information. For example, you're hearing about food as medicine. That's been a big trending topic for years now. The millennials are all about food as medicine and talking about these trends. And there's a lot of amazing work in clinical nutrition and has been done for hundreds of years on making sure you have enough vitamin D and zinc in order to keep your immune system healthy. But that has become so oversized in today's society. And, something that's on the media can have such an amazing impact on people and their healthcare decision-making nowadays. So quite frankly, I think the future of healthcare is not only the science, communication of the science means having good researchers in media that are bringing us up to date about healthcare trends, and then secondly, this barrage of information that we have no control over from crowdsourced websites and social media.
Out of time, but that's okay. As the moderator, I'm going to extend us a little bit of time, because what I want to do, this has been such a fascinating conversation. I want to get closing thoughts from all of you, just in terms of where do you see the industry going? Dr. Keckley, I want to start with you. You have been like the X factor in this panel discussion since you got here. So I certainly thank you for certainly bringing the boom today. Let's start with you in terms of where do you see us headed? And then after you, we'll hear from Ben Harder, and then Dr. Vequist, you'll close us out.
Well, I think it's incremental through the midterm election. And then depending on that outcome, we're either moving more toward expanding Medicare to 60 plus that leads to a broader discussion of a government run option, or the results point us toward accelerated technology enabled self-care in a B2C industry. Where employers have driven that change. I think we're at this kind of interesting crossroad where politics trumps policy, and that vote's going to tell us a lot about what direction the system goes. But bottom line is we can't fund it at its current level long term, so we have to figure something out.
Sure. Yeah, I think that's a great comment, and just building on that and on our prior discussion around the slowness of government action. What we're seeing is increasingly those who are paying for healthcare, whether it's an insurance company or an employer, taking a driver's seat role because they recognize that government isn't going to do it for them, and increasingly homing in on which providers of services, in particular, which health systems do we want to work with, because they give us affordable pricing and high quality of care and good access for our employees or beneficiaries. And so that trend is going to continue, a continued consolidation of hospitals into health systems, and this scramble, this sort of a musical chairs game of health systems and insurers or payers trying to find the right match for them and for the population that they're respectively responsible for.
Dr. Vequist?
Yeah, so I see the future of healthcare as being very individual or personalized, meaning that people are going to want a holistic healthcare medicine that is specific to them. The second thing is I think we're going to continue to see an oversized impact of communication of healthcare from a variety of different people, particularly from the internet and information from the internet affecting healthcare. And third is I really do feel that the future is international, just like almost every other product and service consumed in the United States. There's an international component to it. Healthcare will continue to become more international and therefore will lead to more diplomatic issues in the future.
We've got to leave it there. Those were some really interesting thoughts, a very provocative conversation. Thank all of you for your time today. Ben Harder of U.S. News and World Report, Dr. Paul Keckley of the Keckley Report, and of course, Dr. David Vequist of the Center for Medical Tourism Research. Thanks to all of you. And also I want to thank our sponsors once again, Cigna, Children's Hospital, the George Washington University, Kaiser Permanente, Home Care Connections, and Diplomat Enterprises. And please stick around for the conference. There is the networking session that is taking place right now. And afterwards, in about less than 10 minutes, we are going to have our next panel discussion, COVID-19 around the world, where we will have with us the ambassador of New Zealand, as well as someone from the White House, from the World Health Organization that will talk about this issue. So please stick around for that conversation. Again, thanks to all of you for your time today. And hopefully you are enjoying this conversation and the conference. Thanks so much.
Thank you.
Thank you.
Thank you.